All right.
Okay, thanks.
Let's move on, and then we'll get into more of these discussions, I'm sure, in the future. We also have other questions coming in. And again, I want to invite people to call in, and we'll definitely take priority to the callers. So let's move on to Dr. Cowell now, who's going to talk to us, another talk about associated ocular systemic conditions. Dr. Cowell?
Good morning, everyone.
Good morning.
Good morning.
What time is it there for you right now?
It's 1:36 a.m.
So it truly is morning. Yeah.
You got to go to work in a few hours, Lionel.
Now, this is such a wonderful symposium and such an august faculty, and Lou has already got me quite scared about using words like cause and association. So, Lou, I hope I do okay. The condition called infantile nystagmus is a bilateral conjugate nystagmus where the nystagmus with right fixation is about the same as with left fixation, except if there's strabismus. It has an eccentric null and a convergence null. And the associations that one will see are those that have been mentioned already, albinism, any significant bilateral symmetric visual loss, it's all in red there, that happens at a critical period in visual development in early infancy. So it's bilateral and symmetric. These are the conditions that are associated with infantile nystagmus, and there's the list. There are some systemic associations. The systemic associations that are specific to infantile nystagmus are those genetic causes that have no other ocular findings, for example, the FRMD7 gene. And there are several systemic associations that are specific to infantile nystagmus, and they've also been alluded to, neurological ones, especially periventricular leukomalacia and midline defects. I also going to talk briefly about fusion well-development nystagmus, because we're talking about nystagmus in childhood. And I always teach this as if it's as a bilateral nystagmus that is monocularly driven. So the nystagmus with right fixation is not the same as the nystagmus with left fixation. And if you see torsion on the slit lamp, then it's almost certainly FMN. And the associations of FMN are basically different from those of IN. The main association is an asymmetry in sensory development, an asymmetry in motor development, arising at a critical period in very early infancy. So the commonest asymmetry in sensory development would be a unilateral ocular defect, cataract, etc. And the commonest asymmetry in motor development would be infantile onset strabismus. There are some systemic associations, the same periventricular leukomalacia, and FMN is seen more commonly in children with developmental delay of any cause, especially trisomy 21 and the many associations and causes of cerebral palsy. One issue with nystagmus is, does this child see? The early infantile waveform was shown by Reinek's lab decades ago. The early infantile waveform can be large amplitude, low frequency, and this looks just like purposeless eye movements. And if you have an infant with purposeless eye movements, a very simple and effective test is look for vertical OKN. If the infant has vertical OKN, it's a quick test, easy, cheap test, and it's a very reassuring hint that the child can see. Now, how and when to investigate? I enjoyed hearing Avery's comments, but there's a lot of selection bias in any list of recommendations. Ever since I was an ophthalmology resident, there's been a regular debate, should the baby with nystagmus have an EIG first or an MRI first? I think if it's clear that the infant has poor vision, they need both done first. If the infant has paradoxical pupils, and it's always a great sign to teach the resident, then they need an EIG. If there's any developmental issues or any disc changes, they need an MRI. Locally, I use sweep VEP a lot. I really like this. I treat it like a horoscope. If your horoscope in today's paper is pleases you, you'll believe it. So I enjoy the horoscope value of sweep VEP. It's a really good result, makes me and the parents quite optimistic about the child's future. But I always point out that a bad result might still turn out okay. So I like doing sweep VEP early on in many children with IN. And I like doing eye movement recordings. A little difficult in the infant under 3-4 months, but not impossible. And if it's classical IN, there's less need for any further testing. That's really all I have to say, except to thank Richard and Lou for all their help over the years. They've treated a lot of my patients by remote control, and I need to thank Larry Abel, who's the local eye movement guru, who unfortunately is sick at the moment and not able to be part of our audience, who does consistently superb eye movement recordings, very sophisticated interpretation, and has allowed me to be a much more effective doctor for these complex patients. Thank you.
Thanks very much. That was great, Lionel. There's a couple of things.
Hey, Rich.
Yes, go ahead, Dave.
It's David. Can I ask Lionel something?
Sure.
Sure.
Lionel, one comment and then one question. I had a family. Rich was out visiting, and we had him as a visiting professor. I had a family of 5 kids with achromatopsia, and I recorded 3 of them, and they all had INS. And Rich was looking at it, the 4th, and the kid he thought maybe something different. We recorded him, and the kid had fusion maldevelopment, FMN. Same family, same disease, but that child also had strabismus, and the strabismus sort of won over the INS. So even in the same family, you can see a different recording based upon what might be occurring. That was just sort of a comment that I had, something I learned.
David, with your patient, did the FMN patient also have IN?
Yeah.
Did he have both?
Yes, it looked like it was a mixed waveform, and Rich and Luke can talk about the coexistence of some of these waveforms. But he had strabismus in addition to his achromatopsia. So that was just sort of an interesting combination. But the question I have to you, sorry, Lionel, I know we're going to be time restrained, so I'm trying to get to it quick. The question I have for you was something that we haven't talked about, and that is amblyopia. And the ability to treat the nystagmus patient with amblyopia via patching or atropine or any of the other techniques that we use in amblyopia in any other setting.
Well, there's a little guideline from the literature, and there's what I do. The guideline from literature is really from Hubert Simons, who suggested 25 years ago, roughly, that to treat the amblyopia in a child with nystagmus, and he did not reliably differentiate which type of child with nystagmus, one should keep the child patched for 2 or 3 days at a time. And so that's, as far as I know, that's the only guide in the literature. What I do in real life, I treat them the same as any child without nystagmus. And so in my hands, the results are not very different to children without nystagmus.
That's correct. That Lionel, that's been our experience as well. So actually the fear of patching, especially an FMNS patient where the intensity really dramatically changes, or an INS patient with a latent component, the fear by clinicians initially was the patching made the nystagmus so intense that they figured they were doing more harm than good. It turns out that if you just tell them to patch it and don't patch it in front of you, you feel a lot better, and the patient's vision gets better. So patching works as well in the nystagmus patient as it does in the patient without nystagmus. So there's no reason to shy away from patching or penalization, whatever method you like to use for your amblyopia.
I'll add one other thing for fusion maldevelopment nystagmus. The TNR procedure works every bit as well as it does for INS. I have a paper in review showing that. So that if
How
you're
many
doing
patients,
strabismus surgery and you're only doing one or two muscles, do the other two with a TNR. If you don't do any strabismus surgery, which is what we did on a patient whose strabismus didn't call for correction, we did a 4-muscle TNR and got the same improvement in their nystagmus.
How many patients, Avery?
That's just one.
Lou. Yeah.
Oh, that's one.
I just show that it works. I'm not going to do 1,000 patients.
I think that we are probably going. We're gonna come back. I mean, this is working out very well, but we're gonna take a break, and we anticipate, if it's okay with the panel, everybody, we're probably gonna go a little longer than we thought because this is working out very well. We have some ability to do that on this end, so we'd like to take 10-minute break. Everyone can get up and stretch or do what they have to do, and then we'll be back in 10 minutes. Okay?
So for all the faculty, please leave your cameras on, and then we'll be back here in about 10 minutes. We'll leave our camera on.
What do we do with our phone?
You can leave the phone on too. We're just going to take a little
Okay.
eating bathroom break. So,
Okay, thanks.
Thank you.
okay. All right.